if you live long enough, well, your facial skeleton is going to literally shrink beneath your skin.
Yeah, it's quite a thought.
It really is. I mean, the skull itself degrades, the jawbone thins out, and that whole architectural scaffolding that's holding up your features, it just quietly gives way over the decades.
Right, it's happening to all of us.
Exactly. It's a slightly terrifying thought, but today we are going straight into the brutal millimeter-level engineering required to combat that biological reality. We're decoding the intensely complex architecture of the human face and really the mechanics of facial plastic surgery.
And we're pulling all of this from some really fascinating clinical excerpts found in a foundational medical textbook. It's called Otolaryngology Head and Neck Surgery.
A bit of a mouthful.
Definitely, but it is the definitive manual for head and neck surgeons. It details everything from facial trauma reconstruction to, highly elective cosmetic alterations.
Okay, let's unpack this because I want to frame this deep dive not as some dry medical lecture, but really as a shortcut to looking at your own reflection in a completely new way.
I like that approach.
Right, because we tend to look at faces as these singular organic expressions of emotion. But for a surgeon reading this textbook, a face is essentially a mathematical landscape.
It's pure geometry.
Yes. Before anyone even touches a scalpel to alter a specific feature, they have to map out the overarching geometry of the canvas.
And that mapping process, it relies on a really strict clinical grid. So surgeons evaluate the face by dividing it into horizontal thirds and vertical fifths.
Okay, so breaking it into a grid.
Exactly. They assess the proportions from the trichin, which is the hairline, down to the glabella between the eyebrows for the upper third. Then the glabella to the subnasal, under the nose for the middle third.
Got it.
And finally, from the subnasal down to the mentон, to the bottom of the chin, to evaluate the lower third.
So those structural borders basically create a sort of topographic map of your face.
Precisely.
But the text also highlights these really highly specific anchor points within that grid, right? Like the rhinion and the pregonian. I mean, how do those specific anatomical landmarks dictate what a surgeon can actually do?
Well, they serve as absolute limits for structural manipulation. So the rhinion, for example, is the exact junction where your nasal bones meet the upper lateral cartilages on the bridge of the nose.
Okay, so right in the middle there.
Yeah, and what makes it so critical is that the skin envelope covering the rhinion is actually the thinnest anywhere on the nose.
Oh, wow.
Yeah, there's essentially zero subcutaneous padding there. And then you have the pregonian, which acts similarly for the lower face. It's the anterior most point of the chin.
The part that sticks out the furthest.
Exactly. You have to anchor your measurements to these fixed points to determine if a patient's profile is, genuinely disproportionate or if the underlying skeleton is just aging.
This section on aging in this textbook completely upended my understanding of the whole process.
Oh, it changes everything.
It really does. The cosmetic industry talks endlessly about the skin-like, loss of elastic fragments, decreased mature collagen, vanishing fat. But the true culprit of an aging face is that bone degradation we touched on at the start.
What's fascinating here is how skeletal resorption fundamentally alters the mechanics of the face. Your bones are actually thinning and losing volume, but the skin envelope covering them remains the exact same surface area.
Yes, exactly. I keep picturing a perfectly tailored suit.
Oh, that's a good analogy.
Right. If the person wearing the suit shrinks significantly over 20 years, the suit doesn't magically grow larger, the frame underneath just gets smaller.
So you're left with all this excess fabric.
Exactly, draping off the shoulders and pulling at the ankles.
And that excess skin envelope is really the defining challenge of facial rejuvenation. And it's not just isolated to the cranial and maxillofacial bones either.
What else changes?
Well, the textbook extensively details how the laryngeal skeleton and hyoid bone, so the surface in your neck, physically descend with age.
So gravity's just pulling the actual skeleton down.
Pretty much. The entire supportive matrix weakens, leaving you with hypotonic muscles that create what they call soft tissue festooning.
Which perfectly explains why pulling the skin tight in older traditional facelifts often resulted in that really unnatural, windblown aesthetic.
Right, because they were just addressing the drape, not the frame.
Exactly. If the underlying frame has degraded, just stretching the fabric tighter doesn't restore the original architecture. It just flattens out the topography.
It creates a distortion. That's why modern surgical approaches have to focus on rebuilding or repositioning that deep structural foundation before even considering the tension of the skin envelope.
Okay, so if that skeletal canvas is constantly retreating and shifting as we age, what does that mean for the centerpiece of the face? The nose.
The nose is a whole different ballgame.
Let's zoom in on the specific engineering required to alter that structure, because reading this, the textbook treats rhinoplasty like high-stakes architectural renovation.
It really is. Rhinoplasty is routinely categorized as one of the most unpredictable and difficult operations in all of plastic surgery.
Which is saying something.
Definitely. You are simultaneously manipulating bone, cartilage, and a dynamic skin envelope, all while preserving the delicate physics of the nasal airway.
And the very first hurdle the textbook highlights isn't even the bone, it's the skin.
Yep, the skin thickness.
Yeah, there's this sort of Goldilocks scenario regarding nasal skin thickness. Thicker skin obviously hides tiny surgical irregularities underneath. It acts like a heavy blanket over the cartilage frame.
Right, which sounds like a good thing initially.
But why does the text flag thick skin as such a major liability for postoperative healing?
Well, thick skin carries an immense propensity for severe postoperative edema or swelling. And more critically, it forms substantial subcutaneous scar tissue.
It just holds onto everything.
Exactly, it holds onto fluid and biological memory. Conversely, incredibly thin skin resolves swelling rapidly and forms minimal scar tissue.
But I'm guessing there's a catch there too.
A huge one. It acts exactly like industrial shrink wrap. As it heals, it will brutally reveal every microscopic edge, unfiled bone fragment, or slight asymmetry in the cartilage beneath it.
Wow, so you really can't win.
It requires an incredibly precise surgeon.
And once a surgeon evaluates that skin envelope, they move to the profile, relying on honestly protractor level math. The text outlines strict aesthetic ideals, like a nasofrontal angle of roughly 120 degrees.
The angle between the forehead and the nose.
Right, but why that specific number? Like, what is the visual logic behind these exact degrees?
It has everything to do with light reflection and optical illusions. The nasofrontal angle actually dictates the perceived length of the nose.
Okay.
So if you deepen that angle, make it sharper, the nose visually appears shorter. If the angle is too shallow, the profile looks heavy and elongated.
Then we have the columellar labial angle, which is the intersection of the upper lip and the base of the nose. The ideal metric for men is 90 to 105 degrees, while for women, the text suggests 95 to 110 degrees.
Right. And that slightly more obtuse angle in female rhinoplasty creates an upward tilt, which interacts with the projection of the upper lip to create a much softer shadow profile.
That makes sense.
Furthermore, a highly refined nasal tip relies on what surgeons term a double break.
A double break?
Yeah. Rather than a single sharp converging point at the tip, an ideal tip features a super tip break just above the apex and infratip break just below it. This geometric configuration catches ambient light in a very specific, multifaceted way.
But the textbook notes that to achieve those exact degrees in that specific double break, surgeons rely on something called the nasal tripod model.
Yes, the tripod theory.
This fundamentally changed how I view the human face. The tip of the nose is literally engineered as a mechanical tripod. I mean, is this exactly like adjusting a camera tripod? If you shorten one leg, does the whole structure just tilt?
It functions exactly like a camera tripod. The major support for the lower third of the nose comes from 3 distinct cartilage legs.
Okay, where are they?
So the conjoined medial crura, which run down the columella between your nostrils, act as the central strut.
A middle leg.
Right. Then the 2 lateral crura, which curve outward over the nostrils, act as the remaining 2 legs. This specific dynamic tension dictates both tip projection. So the horizontal distance of the nose extends from the face and tip rotation.
So if a surgeon wants to increase upward rotation, they physically shorten those 2 lateral crura, pivoting the entire tripod upward.
Exactly.
But if they need to push the tip further out from the face to increase projection, how do they alter that central leg to handle the increased load?
Well, they have to reinforce the central strut. The textbook extensively covers the use of a columellar strut graft.
A graft, so they're adding material.
Yes. The surgeon harvests a rigid piece of autologous cartilage, usually from the septum, and wedges it directly between the medial crura. This essentially props the central leg of the tripod up, ensuring it can withstand the compressive forces of the healing skin envelope.
Understanding this mechanical tripod is fascinating, but reading about how a surgeon actually accesses these millimeter-level structures is another story. This brings us to the renovation phase, the surgical approaches.
Right, and before any incisions are discussed, the text establishes a non-negotiable principle,
Which is?
always err on the side of conservation of tissue rather than resection.
Because form can never supersede function.
Absolutely not. The second you resect too much structural cartilage, you collapse the internal nasal valve and, well, you destroy the patient's airway.
And the physics of nasal airflow are incredibly unforgiving.
Very. But assuming the surgeon respects that boundary, they must choose an access route. The primary options are the non-delivery approach, often called closed rhinoplasty, and the open or external rhinoplasty.
So the non-delivery approach relies on incisions made entirely inside the vestibular lining.
Inside the nostrils.
Right, so no external scars, drastically reduced trauma, and less disruption of the lymphatic drainage pathways. But the text notes severe limitations regarding exposure.
Huge limitations. The surgeon is essentially operating blindly within a tight mucosal tunnel.
That sounds terrifying.
It requires a lot of feel. It is primarily reserved for highly conservative dorsal refinement or minimal tip work, simply because the lower lateral cartilages cannot be fully visualized in their natural resting state.
Here's where it gets really interesting.
The open approach.
Yeah, the open rhinoplasty approach utilizes those same internal incisions, but connects them via a transcolumnar incision right across the base of the nose.
And once connected.
They literally peel the entire skin envelope upward, completely degloving the cartilaginous framework. I like to think of the open approach as lifting the hood of a car so you can rebuild the engine block with total visibility in both hands.
It's a very accurate visual.
And the closed non-delivery approach is like trying to fix that exact same engine by reaching your tools up through the tailpipe.
If we connect this to the bigger picture, the open approach provides maximal undistorted exposure of the entire nasal tripod.
So they can see everything.
Everything. The surgeon can assess natural asymmetries, meticulously suture cartilage grafts into place, and secure structural reinforcements with absolute geometric precision.
Which makes it the go-to for complex cases, right?
Exactly. It has become the gold standard for complex revisions, severe traumatic deviations, or extensive reconstructive grafting.
The trade-off, however, is a massive increase in postoperative edema. By lifting the skin envelope, the surgeon severs countless microscopic lymphatic channels and minor support ligaments.
Right, the swelling can last for a very long time.
And you also run a high risk of transient or even permanent sensory disturbances in the nasal tip.
It perfectly illustrates the constant surgical tension between achieving aesthetic perfection and preserving vital anatomy. And nowhere is that tension more brutal than when addressing a prominent dorsal hump.
Yes, the hump. We generally assume a bump on the bridge of the nose is just a solid mass of bone.
A lot of patients think that.
But the text clarifies that most hump deformities are composite structures, largely composed of the cartilaginous dorsum in the middle third of the vault.
Right, and the initial reduction involves a down-biting rasp.
Which is essentially a coarse surgical file.
Yes, an instrument used to literally file away the excess bone and shave down the cartilaginous septum until the profile is perfectly straight.
But executing that reduction creates an immediate massive architectural failure.
It does.
Because the upper two-thirds of the nose is structured like a steeply pitched tent. When you rasp away the apex of a tent, you don't just magically get a lower intact peak.
No, you create a flat plateau.
Exactly. A flat plateau with a gaping hole in the center. The textbook terms as an open roof defect. The internal nasal mucosa is suddenly exposed directly beneath the skin envelope.
And leaving an open roof defect is structurally disastrous. To close it, surgeons must execute bilateral osteotomies.
Which means breaking the bones.
They use precision chisels to intentionally fracture the nasal bones medially along the septum and laterally low down along the maxillary junction.
So they completely free the bony side walls of the nose from the skull so they can physically push them inward, closing that open roof defect and restoring a continuous bony vault.
It is literal heavy-duty mechanical engineering.
It's wild to think about.
And it requires intense calculation. Narrowing the bony vault excessively triggers the Bernoulli principle within the airway.
The fluid dynamics principle.
Yes, as the internal radius of the nasal valve decreases, airflow velocity increases, which drops the internal pressure.
Okay.
If the side walls are weakened from the osteotomies, that negative pressure will actually suck the lateral cartilages inward during a deep breath, causing complete dynamic airway collapse.
So you breathe in and the nose just pinches shut.
Exactly.
To combat that exact airway collapse, the text details the deployment of spreader grafts. Surgeons harvest tiny rectangular slivers of cartilage and wedge them firmly between the septum and the fractured nasal walls.
It's basically physically propping the internal valve open, like microscopic doorstops.
Microscopic doorstops.
They restore the necessary width to the middle vault, ensuring the airway remains patent even under the heavy scar contracture of the healing phase.
With all this intensive rasping, intentional fracturing of bones, and wedging of structural cartilage, it's inevitable that the underlying biology sometimes rejects the mathematics.
It happens more often than people realize.
Which brings us to the aftermath and the incredibly complex nature of surgical complications. So what does this all mean? How often do things go wrong?
Well, the textbook does not shy away from the statistics. Approximately 10 to 15% of all primary rhinoplasties require formal revision surgery.
That is a significant percentage.
And standard protocol mandates waiting a minimum of 1 full year before reoperating.
A 12-month waiting period seems excruciating for a patient dealing with a compromised result.
It is. But the text emphasizes that it takes a full year for the initial edema to entirely subside and for the highly reactive scar tissue to soften and mature.
Those surgeons actively try to mitigate these risks long before the first incision by screening out poor candidates, right? Unrealistic psychological expectations are obvious red flags.
Absolutely.
Yeah.
But physiologically, the absolute worst case scenarios involve heavy smokers.
Right. Why is that so specific?
The physiological impact of nicotine is devastating to surgical outcomes. Smokers carry a greater than 12-fold increased risk of skin sloughing.
Sloughing meaning complete necrosis or death of the skin envelope.
Yes, and massive unyielding scar tissue formation. Nicotine acts as a severe vasoconstrictor, entirely choking off the microscopic capillary blood supply that the freshly undermined skin desperately requires to survive.
But even in ideal candidates with stellar blood supply, the dynamic nature of human healing can ruin flawless surgical execution.
Oh, absolutely.
Biology has its own way.
Right. The text outlines several late-stage structural failures, one of the most notorious being the polybeak deformity.
The polybeak manifests as a convexity, or a prominent soft tissue bulge, centralized right in the supertip region of the lower dorsum, giving the profile a distinctly parrot-like appearance.
Hence the name.
The obvious assumption is that the surgeon simply failed to resect enough cartilage from the dorsal septum, like they just missed a spot.
That happens, but the text highlights a far more insidious cause. Soft tissue scarring and creation of dead space.
Wait, so the scar tissue actually creates the hump?
Yes. The body absolutely abhors a vacuum. If a surgeon aggressively over-resects the underlying cartilage, a void or dead space is left between the skeletal frame and the heavy skin envelope.
Okay, so there's an empty pocket.
Right. Hematomas fill that void, and fibroblasts rush in, rapidly organizing into dense, rigid collagen. This aggressive scar tissue pushes the skin back up, recreating a prominent hump solely out of scar contracture.
That is just wild. So the treatment pathways must diverge based on the cause.
They do. If the surgeon diagnoses soft tissue scarring early in the healing phase, they inject targeted corticosteroids directly into the supertip to break down that dense collagen matrix.
But if it's an underlying structural failure, the patient is headed back to the operating room.
Unfortunately, yes.
Then you have the inverted V deformity, which, just by the name alone, sounds like a catastrophic architectural collapse.
It is an architectural failure, and it often doesn't even become visible until years post-operation when the thick skin envelope finally thins out with age.
Oh wow, so it's a delayed consequence.
Exactly. The inverted V occurs when the upper lateral cartilages violently detach from the nasal bones and collapse inward into the airway,
Which leaves the sharp, lower horizontal edges of the nasal bones visibly protruding through the skin.
casting an upside-down V shadow right across the middle third of the bridge.
And the text says it usually coincides with severe saddling, right?
Yes, saddling is a deep concavity resulting from catastrophic over-reception of the septal support structure. So the bridge basically caves in.
How do you fix that?
Repairing an inverted V or a severe saddle deformity requires massive structural reconstruction. The surgeon must harvest substantial amounts of robust robust cartilage to rebuild a collapsed vault.
And while septal cartilage is the preferred autologous material, I imagine revision cases usually feature a completely depleted septum,
Exactly, the material is already gone.
which forces the surgeon to harvest conchal cartilage from the ear, or for major structural deficits, they actually resort to harvesting costal cartilage directly from the patient's ribcage.
Harvesting rib cartilage provides abundant, rigid structural material, but it introduces a really frustrating new variable.
Because ribs aren't noses.
No, they aren't. The textbook explicitly warns about the inherent memory of hostile cartilage. Over time, rib grafts have a high propensity to spontaneously warp and curl within the nose, distorting the newly reconstructed framework.
So it's just never ending. We're talking about unpredictable scar tissue filling dead space, lateral cartilages collapsing into the airway, and harvested rib bones warping years after the fact.
It's a lot to manage.
How do the leading surgeons, and honestly the patients signing up for this, navigate a landscape fraught with such uncontrollable biological variables?
This raises an important question regarding the fundamental limitation of aesthetic surgery, the sheer unpredictability of human biology. A surgeon can execute the flawless mathematical reduction of a dorsal hump, orchestrate perfect osteotomies, and intricately suture the nasal tripod to exact textbook specifications.
But scar tissue possesses an independent memory.
Precisely. Asymmetrical healing, the relentless downward force of gravity, and cartilage warping exert continuous pressure over the lifespan of the patient.
It's a lifelong commitment.
That's why the initial psychiatric assessment is paramount. Patients must understand they're engaging in a dynamic, lifelong process of structural management, not purchasing a static, perfect result.
It fundamentally reframes the entire concept of facial cosmetic surgery. I mean, we've moved from mapping the clinical grid of facial thirds and fifths to unpacking the complex mechanics of the internal cartilage tripod.
We covered a lot of ground.
We really did. We've analyzed the intense physics behind rasping bone, executing osteotomies, and managing airway resistance. And ultimately, we've seen how all of that elite engineering is subject to the ruthless, unpredictable variables of the human healing process.
The most profound takeaway is realizing that plastic surgery is never merely a superficial draping of skin. It requires the systemic alteration of your deep skeletal architecture and the physiological mechanisms that allow you to breathe.
So the next time you look in the mirror, I highly doubt you'll just see a static face staring back at you.
You'll see the blueprint.
You are going to see the grid. You're going to visualize the underlying skeletal canvas that is slowly, inevitably thinning and retreating. You'll recognize the immense tension of your skin envelope, and you'll see the microscopic tripods of cartilage fighting against gravity to hold everything in place.
You are looking at a living, dynamic architectural structure.
An incredibly fragile masterpiece of biological engineering.
Very well said.
But I want to leave you with a final thought, building on all of this brutal structural math and the unpredictability of harvesting bone and cartilage.
Okay.
If facial beauty, the visible perception of aging, and the success of these intense surgeries are fundamentally dictated by geometric ratios, skeletal volume, and cartilage resilience, how might emerging technologies completely upend this entire textbook?
Oh, that's a great point.
Right, imagine a landscape just a few years out where surgeons don't have to harvest a rib that might warp. What if we could utilize 3D printed, biologically inert, perfectly matched cartilage matrices to reinforce your facial scaffolding before it even begins to degrade?
It would eliminate so many variables.
Exactly. If we can perfectly, indefinitely maintain the deep structural frame of our features without relying on unpredictable autologous grafts, how might that completely redefine what it means for the human face to age naturally?
It's a paradigm shift.
Something to think about the next time you catch your profile in the reflection of your screen.